If you're in menopause or perimenopause, one of the most common questions I get is, should you start testosterone with hormone replacement therapy? And it's a very interesting question, and I'm so happy we're having this conversation because for many years since the Women's Health Initiative came out, there's been a lot of stigma around hormone replacement therapy, and I'm happy to see now that they removed the black box warning against estrogen, and these conversations are starting to become more and more common. So in this video, I'm going to just break down what is menopause, how I look at testosterone replacement therapy to see if it's right for my patient, what the differences are, and how I view it differently between menopause and perimenopause. So first of all, to have this conversation, we need to have a very clear understanding of what menopause is. The definition of menopause is no periods for a year without any other condition causing that to happen. For example, if I put someone on birth control pills and they don't have periods, that would not be considered menopause. Or if you had some sort of thyroid or prolactin issue, that is not considered menopause because there's a medical reason causing it. Anytime before that day, because menopause is a day, like I said, 1 year after your last period, anytime before then is called perimenopause, and then everything after that is postmenopause. And it's really important to understand this to have a actual good understanding of testosterone and its connection to all this, because when you look at the menstrual cycle, you'll see the beginning of the cycle is called the follicular phase, which goes up with estrogen, and then it drops. You have something called an LH and FSH surge, and then you have the second half, an increase in progesterone and estrogen, and then there's a drop, and that's when you bleed and have a period. Notice nowhere in there did I say testosterone. There are some changes of testosterone in the cycle, especially near ovulation, that actually increases your libido a little bit, but is not directly related to menopause. In general, testosterone, if you see the estrogen progesterone, it is a sharp decline over a few years, versus testosterone, it does drop in women, but it's actually more similar to men, where it's a gradual decrease in time. So although it decreases, it's not directly related to menopause. And that becomes really important when you talk about treatment and how you view it. So I'm going to start with menopause and postmenopause. How do I view treatment, and should you take testosterone? Again, everything I'm going to say here is my general guidance on how I think about this. Every patient is different, and obviously talk to your healthcare provider before taking any actions. But when I'm talking about someone in menopause, again, they have not had a period for a year, and they're suffering mostly from what I call classical symptoms, which is the hot flashes, the night sweats, the vaginal dryness, and someone has those symptoms and they're in menopause, I never start testosterone first. I always start them on estrogen and progesterone. And the reason why I do that is I need to fix those symptoms. I need to know, how do they feel with estrogen and progesterone? Does that mean they won't benefit from testosterone? They may or may not, but how do you know what's making things better? So the first thing I do is I treat them with estrogen and progesterone, and we can make another video on the different methods of taking estrogen and progesterone, but that's a topic for another time. You want to baseline get their symptoms. You want to get their hot flashes under control. You'd like to get their sleep under control. You may add some vaginal estrogen for atrophy symptoms and genital urinary syndromes, but you want that controlled first, because then you can then see, is it worth it to take testosterone? And this is a more nuanced conversation, and I'll explain to you why. If someone comes to me and they have just general menopause symptoms, I technically don't need to do labs. It is a clinical diagnosis. Do I think there's benefits to doing labs at the time? Yes, because I'm of the belief that whatever you track, you can change. And when you're treating symptoms and it's a yes-no answer, you can't really dial things in. And this comes into the testosterone conversation. Some people in menopause will feel perfect in that situation and we are done. Some people will still say, "Doc, I still have less energy, weakness, my body composition is still changing," and they still have some syndromes of low testosterone. Their libido's down, etc. And it's also very important to note that currently the only on-label use for testosterone in women is having a libido issue in menopause. If you talk to a lot of women on testosterone, they will tell you there are many other benefits, but it's very important to emphasize what the actual current indications are for treatment on label. So if a woman is complaining of those syndromes, or there may be some other benefits to testosterone, I will start them after, but that requires a lot more follow-up and work. And why is that? If I give someone a little more estrogen or progesterone, their symptoms don't tend to be very different if they're in a therapeutic range. Also, when you give someone testosterone and it is too high, there could be secondary effects that are sometimes permanent. You can have enlargement of the clitoris, you can have deepening of the voice, which can be permanent. They can have some hair loss, they can have some excess hair growth. So it's very important. You have to be very precise. Estrogen, progesterone, you can be very precise, but generally for treatment resolution, you just need to give it, and it tends to be beneficial. It's one of the best, most important changes for quality of life for women, estrogen, progesterone, and also decreases most of the risk factors. Another reason people sometimes feel better on testosterone is there is a conversion between testosterone to estrogen. So it's very important also to understand, is the benefit actually from the testosterone or the fact that it's changing to estrogen, which is why in this situation, I don't start with testosterone first. I want to control those symptoms and know if it's worth it. And when I'm having this conversation with patients, I really sit down and I ask them, because there's no right answer here. You'll see on the internet people really pushing testosterone therapy, and they're talking about its benefits. But if you look at the people they're talking to and that they're emphasizing on, are people that tend to be in a more athletic community. They're looking for wellness optimization, and they're very into their own health. And that's amazing and awesome, but they're looking for tweaking and optimization. But that comes with a price of needing a lot more follow-up and time, and also tweaking. And that is a legitimate cost. And if you're willing to do those things, great. But also, I don't think anyone should be doing that if they don't need it. So if a patient tells me, hey, with the estrogen, progesterone, I feel perfect, I'm fine, my libido's great. Some women don't have much of a decline in testosterone in menopause. Some do. I usually leave them alone. They do not need it. If I do start testosterone, it has to be a gradual process. And when we're talking about testosterone replacement, we're talking about replacement. We're talking about physiological levels, meaning what someone's body naturally produces. I'm not talking about giving people over the amounts, because that's when you get into situations that we talked about before, lowering of the voice, having your clitoris grow longer, having those masculinization qualities. So I generally reserve that for people who have benefit and are willing to do the work, because the difference between a poison and a medicine is in the dose, and it's different for people. The other thing to note is that the only studied testosterone mechanism in the literature is a patch and for the libido, and they did a study showing 150 micrograms versus 300 micrograms a day, and the 300 microgram patch is what showed use. That is not available in the United States. So we end up having to use other methods like androgel, a cream, injections. Some people do pellets, which I'm not the biggest fan of, and I definitely never use it as a first therapy. So that is how I approach it specifically for women in menopause. Let's move on to perimenopause. When someone is going through perimenopause, I then assess how far away are they from menopause and what are their symptoms. If they're giving me, let's say they're mid-late 40s, their symptoms are the same as they were in menopause. They're complaining of the hot flashes, night sweats, etc. I treat them exactly the same way, really, as in menopause, and I usually prefer to have some lab criteria, some labs to kind of guide me there as far as treatment goes. And I like to get those symptoms under control first. The part where this gets more interesting is when we talk about younger women, because people can have perimenopausal symptoms up to a decade before menopause. And if you think about the normal age of menopause being between 45 and 55, and the average age being 51, and it can be 10 years beforehand, there can be women in their 30s suffering from perimenopausal symptoms. And that gets a little more hard to deal with, because usually the symptoms, sometimes they're the classical symptoms, is they're talking about low energy, fatigue, and these basic, sometimes even like ringing in the ear, some tinnitus, some joint pain. And it tends to sound they're like these very vague symptoms. And it's very hard to treat because you don't know what's causing them. And for a lot of times, these symptoms were just ignored. But I usually compare this, when someone is pregnant, for example, and they have a big belly, they'll complain of weakness, fatigue, short of breath, and a bunch of these symptoms. And we kind of joke around saying, well, you're either having an issue, you're having a heart attack or something bad, or you're just pregnant. And it kind of similarly works with menopause. You're either in perimenopause or you're stressed, right? Like imagine, if you put yourself in the head, imagine you're 42 years old, you have, let's say, 3 kids at home, you're in no sleep. How do I know if it's perimenopause or you're just very stressed with life? And when I generally talk about hormone replacement, I usually explain it like a pyramid. You have your stress hormones on the bottom, you have your thyroid and your sex hormones on top. You need those bottom layers figured out first, which is why specifically I always check labs in these patients, and I always check their thyroid and a few other things, and I always talk about them like lifestyle changes first to figure out what their baseline is. From there, some of these women, by the way, their estrogen's fine and their progesterone's fine, and they're complaining a lot of irritability, anxiety. Sometimes these patients' progesterone and estrogen are fine, and I will actually just start them on testosterone. And something that people don't think about is about 1 in 5 women in the U.S. are on testosterone, on some sort of estrogen. About 20% of patients, which is 1 in 5 women in the U.S., is on an antidepressant. And if you look about the changes in this age range, if someone came to me with those symptoms and they had low testosterone, I would happily start them on testosterone first to see how it works before starting them on an SSRI. And some women, actually, there's some studies out there now that show even on an SSRI, they may still benefit from testosterone therapy. So when we're going through the treatment algorithm, that is how I generally approach it. When we're getting into earlier patients, like let's say they're in their 30s, especially around like 35, for example, there's another thing that people don't always consider. Did we cause these symptoms? Is a patient on birth control pills? Because when you start giving people medications that increase a hormone called sex hormone binding globulin, it may suck up your hormones. We may be the ones causing it. So we may talk about either changing the method of birth control or giving them a supplement like DHEA, because there was a paper, for example, in 2017 that giving them DHEA may restore the testosterone of a patient before they were started on the birth control pills. So that is a more in-depth conversation. And you really, really, really want to rule out any medical issues specifically for these younger women having that conversation. This is a very nuanced topic. It is something that actually really excites me because it is a therapy that I think does an incredible job at restoring quality of life to a lot of patients. And it is something that has been slept on for many years, even though there's been many, many decades of research supporting its use. Let me know if you want any videos on how to dose testosterone, hormone replacement in general, risks, benefits, etc. I'll see you in the next video.